Welcome back, clinical problem solvers, to Rafin Medina subspecialty VMR series. Today, we are thrilled to host a cardiology VMR with Dr. Stephen Pan and Dr. Sukriti. And let me introduce myself. I'm Rahul, one of the internal medicine residents and a CP Solvers Academy member. Um, so before I introduce our case presenter and discussant, I really want to thank people who is making the session possible. And first of all, thank to Shreya for doing the teaching points. And thank you so much, Deborah, for the backup. Valley was not available today, and she was so happy, and she was doing the scribing today. And and before we dive in, let me introduce our case discussant, Dr. Stephen Pan. And Dr. Stephen Pan, we are very absolute honored to welcome you today. So Dr. Stephen Pan was born in New York, completed his undergraduate degree at Columbia University, and attended medical school at the University of Pittsburgh, followed by further training in internal medicine, bioinformatics, and cardiovascular disease at Stanford Hospital in California. He completed an additional fellowship in heart failure and transplant cardiology at Columbia Presbyterian Hospital in New York, after which he was an assistant professor of medicine at NYU, where he also served as the co-director of the cardiac sarcoidosis program before relocating to Westchester as the director of the infiltrative cardiomyopathy program. Dr. Pan is passionate about helping people with heart muscle diseases, especially those with infiltrative disease of the heart, including a cardiac amyloidosis and sarcoidosis and inherited genetic disease of the heart, such as familial cardiomyopathy. He has conducted research, including clinical trials in cardiovascular genetics, novel heart failure therapeutics, and heart recovery after ventricular assisted devices and infiltrative diseases of the heart. We are so grateful to have you with us, Dr. Pan, today.
No, thank you guys for the very kind introduction, and thank you for inviting me to be here. Hopefully, it's a great discussion, and I look forward to hearing more about this case.
Thank you so much. And let me introduce our none other than our Sukriti, a CP Solvers Academy member and PGY5 cardiology fellow at Henry Ford Providence Hospital, a visual learner and a self-taught artist. She loves to learn using art as an aid to simplify all the complex concepts in medicine with a focus on adult congenital heart diseases. She is the author of Learning Medicine with Art, a compilation of medical illustrations which aims to make learning fun for the medical student. She hopes to pursue a career in adult congenital electrophysiology. Thank you so much, Sukriti, for taking your time and presenting the case with us today.
Thanks for having me, Rahul. I'm so excited to learn from Dr. Pan today.
We are so excited and happy to learn from both of you. So, Dr. Pan, before we start, I have a question for you. What inspired you to pursue your career in infiltrative cardiomyopathy?
Wow, that is I can talk about that for hours, frankly. I always had an interest in cardiovascular genetics. To try to keep this brief, I did a lot of research in genetics in my during my training. And if you'd asked me that at that time, I would have told you that I was planning on doing a career in either familial cardiomyopathy and possibly hypertrophic cardiomyopathy. As luck would have it, when I relocated to New York and took my first job at NYU, honestly, as was told to me, and as I always tell to my trainees, you can always prepare for the plan that you want, but you should always be prepared for any diversions from that plan or any opportunities that fall in your lap. Basically, my boss literally just came to me and said, "Hey, do you wanna try your hand at cardiac sarcoidosis, because we're in need of a cardiologist to focus on that." And there was no one else who was going to do it, so it became me. And I think that sort of snowballed into, because there's so many similarities in how patients present with both sarcoid, amyloid, and other infiltrative diseases of the heart is sort of generalized to a whole infiltrative cardiomyopathy focus, which is sort of what I do now. And just to go full circle, I think a lot of what I do also involves cardiovascular genetics regarding familial amyloid disease, as well as many mimics of cardiac sarcoid are actually familial diseases such as ARVC. So I think it all sort of came around wrapped in one big hodgepodge of, cardiomyopathies that present with an arrhythmic component. And thicker hearts, basically.
Wonderful. And we are so lucky to learn from you today. And one more question. So, what do you do outside of medicine?
Not much, I have to say. I have two young children. They're actually turning 6 and 4 this week, so that takes up a lot of my time, to be perfectly honest. In a former life, I did used to swim and play tennis, but I can't say that I do that too much anymore, to tell you the truth. So.
Wonderful. And all right, thank you so much. So, without further ado, let's get started. And Deborah, once we have a whiteboard ready, and Sukriti is going to present her first aliquot. All right, Sukriti, the stage is yours.
Thank you. So I just want to say I've had, the pleasure of learning from Dr. Pan outside of VMR while writing a paper with him. And so I've always wanted to round with him. So I'm gonna just set the stage here. Dr. Pan, we're both in the clinic, the heart failure clinic today. And I'm staffing a patient with you. So we have a 31-year-old female that is referred to the heart failure clinic by her general cardiologist for a newly diagnosed heart failure with reduced heart failure with reduced ejection fraction. And I'm gonna stop there, just because I'm really curious if how you would approach heart failure in such a young patient.
Yeah, so that is a great start, I have to say. I think one of the things that brings this case to light really right now is, as you may all be aware, the recent HF Stats epidemiology report came out and showed that actually the age of presentation for heart failure is actually declining, which is kind of shocking because we always think traditionally of heart failure as a disease of the elderly. But what we're learning more and more nowadays is that with better diagnostic techniques and maybe just a general change in how the disease is presenting, we are seeing younger and younger patients. And I'm always fearful of that because I always tell the people I run with, my trainees, that, I can deal with the 65-year-old gentleman with heart failure. I sort of, oftentimes they've had time to sort of compensate, and I can sort of make a good guess as to how sick they are based on my, physical exam and seeing them. But young people always scare me because young people tend to compensate for quite a while, and then they just break. I hate to say it that way, but oftentimes I always talk about presentation of heart failure in a young person as analogous to like basically a river and a dam, and really they can really hold back the flooding waters quite a bit until finally one day that dam breaks, and then these patients can go from being totally fine walking around doing martial arts, for example, as one patient I remember very well in my head, to basically being extremely sick on mechanical support within a matter of days. So really, my approach to the young patient with heart failure is one that's very much with trepidation. Let me put it that way, because these are the patients I actually worry about the most, to tell you the truth. In a young woman like this, 35-year-old woman presenting with a HFrEF, I think for the most part, you can pretty much put ischemic heart disease very low on the differential. I would never say that it's completely out of the picture. And of course, when you're thinking about ischemia in younger women, you have to think of rarer things like spontaneous coronary dissection and vasculopathies, not necessarily atherosclerotic disease. But because those are so rare, we generally do not think that patients of that age, unless there's some other part of the history that's intriguing, absolutely necessitate an ischemic evaluation. I think, however, that being said, when you move over to the bucket term of a non-ischemic cardiomyopathy, which of course is a is a term that I particularly hate to say that, because it's like calling your bathroom the not kitchen. You're describing something by what it's not, when there are so many things that it could be. And then that's really the point here is in a young person like this with a presumably non-ischemic cardiomyopathy, the book is wide open. It could be infiltrative, it could be familial, it could be um, acquired diseases like sarcoid, myocarditis. So really, at this point, I think the focus of the history here is really going to revolve around trying to figure out the time course, because the time course of symptoms and how long it's been going on, as well as family history, by the way, will help narrow down your sort of differential diagnosis.
Thank you so much, Dr. Pan. Sukriti, do you want to give the secondary report?
That was great. So to give you more history, Dr. Pan, this 35-year-old female. She first saw her cardiologist for increasing frequency of palpitations and chest discomfort since a few months. Um, as far as the palpitations, she first experienced this over 10 years ago, but the episodes were very infrequent at first. However, they're present every day now, and that's what prompted her to seek more help. She describes them as feeling as if her heart is racing, and they're associated with lightheadedness, but there's been no history suggestive of transient loss of consciousness. Over the last month, she's quit coffee, alcohol, chocolate, but there's been no change in her symptoms. She has had workup for the symptom as far as having a cardiac event monitor that was placed in the remote past. At that time, there was nothing came off it. The results were essentially unremarkable. But because of her recent worsening of symptoms, another cardiac event monitor was placed. This revealed episodes of sustained VT, and her general cardiologist subsequently referred her to an electrophysiologist. During the same time, she'd also described episodes of chest discomfort that felt to her as if there was some fullness in her chest. It was present for a few minutes, but it was severe enough for her to go seek care at a nearby urgent care. There, an ECG was done, which showed sinus rhythm. However, there was 2 millimeter ST segment elevation in V2 with concern for STEMI. So she was sent to the ER where it prompted ischemic workup. A left heart cath was done, which was essentially unremarkable. And I'm gonna stop there just to get your thoughts. I know that was pretty dense.
No, that was great. You had me a little scared there when you talked about the 2 minute ST elevation. I was like, oh no, is he really going to be ischemic at the end of the day? So at least I was a little relieved that the cath was negative. But of course, that sort of gets me back to my original point is this is a very broad differential. And I think now you're stuck with this young woman with a non-ischemic cardiomyopathy and VT, which I think is a very significant portion of this now that really raises a lot of questions as to what's going on. It sounded like, and correct me if I'm wrong, that this was some more of a subacute process. Is that correct? So it didn't sound like this has been going on for years. So then you're sort of talking about things that really are acquired sort of cardiomyopathies that then can present with both heart weakness. I haven't heard her ejection fractions, but I assume she does have HFrEF based on the stem here, as well as arrhythmias. And I think for me, of course, the things that jump to the top of the list are inflammatory disorders, especially in a young woman. So things like myocarditis, both viral as well as other forms of myocarditis. And then, of course, sarcoidosis, which some people actually sort of say is a form of myocarditis, just a special form of myocarditis that's related to granuloma formation. I didn't hear anything about past medical history about autoimmune disorders, but especially if this woman had a history of an autoimmune condition or even just rashes and joint pains, that would also further work up there because, again, other forms of myocarditis other than viral include autoimmune myocarditis, such as those related to lupus, scleroderma, etc., which, especially in a young woman like this, those signs of those sort of rheumatological conditions may be quite subtle. They should be there if she has myocarditis, but they might be more subtle and they might not have been caught yet at that point. And of course, just given her age, we haven't talked about family history, but given the VT, I again go back to possible familial presentations. Again, you would think that those would have had symptoms starting earlier. Usually when I see a patient who I highly suspect of familial disease, even though it may sound like a lot of the cardiac symptoms may have been more recent, once you start asking, they'll say things like, oh, I've always had extra heartbeats, or, I was told once that my EKG was irregular, 10 years ago when I had a physical. So then you learn that even though they may not have felt something until more recently, there has been some pre-existing sort of abnormalities that stem farther back. At this point, I would add, if you're talking about how would you then proceed with sort of figuring what this is, I think. Oh, and one other thing I would say is there is, of course, the possibility that the arrhythmia comes first and the cardiomyopathy comes later. So she has some sort of primary arrhythmic syndrome. So a classic one of that, it would be like basically Purkinje fiber VT, which my understanding, I'm not an EP guy, but my understanding is something that can be found in a young person that's actually quite fixable. That could cause the cardiomyopathy. So it's like sort of a chicken and egg thing, which came first. And so then you're talking about something related more to tachyarrhythmia or PVC related cardiomyopathies as well. In terms of the workup for someone like this, I think we still need a lot of the physical exam, past medical social history. But I think the thing that we always trigger for, if we are able to get it, and that's a big issue geographically, is whether we can get a cardiac MRI.
Thank you so much, Dr. Pan. Actually, you read my mind. I was able to ask that question, whether any arrhythmia is going to cause a cardiomyopathy. Yeah, and wonderful wisdom within the short pool. Back to you, Sukriti.
That was so awesome. So to give you more history, so we did a review of systems, where so she did say that she'd been experiencing hip pain, and she was told that she had, quote, osteoarthritis. But other than that, there was no history that was suggestive of bilateral carpal tunnel syndrome, anything that was suggestive of biceps tendon rupture, GERD, atrial fibrillation, neuropathy, and other than her palpitations and her chest discomfort, there were no other symptoms or symptoms of heart failure, including orthopnea, paroxysmal nocturnal dyspnea, or swelling of her legs. As far as her past medical history, for the most part, it's been unremarkable. However, she did have a history of scoliosis with spinal fusion a few years ago. She also had two herniated discs with subsequent radiculopathy. Her medications include oral contraceptive, as well as now metoprolol succinate, 25 milligrams. Her family history, her grandmother was diagnosed with congestive heart failure at the age of 59. She has two brothers who are 32 and 27 years old and are both healthy. Other than that, there was no other history of congestive heart failure, sudden cardiac death, or premature coronary artery disease in her first generation family members, first, second, and third, actually, except for her grandmother. Um, Other than that, I just also did want to make a note that she has had two children, and her pregnancies have been uncomplicated. Her first pregnancy was uncomplicated, but her second pregnancy was complicated by gestational diabetes. But other than that, there was nothing else that prompted like prolonged NICU or ICU during that pregnancy. She is a social worker at a school by occupation. And as far as her habits, she did drink alcohol socially, but she's quit since her symptoms started, and there's no history of smoking or recreational drug use. And I'll stop there.
So yeah, I mean, I think for better or for worse, that unfortunately doesn't narrow anything down. The osteoarthritis of the hip, It's interesting because, I wouldn't necessarily associate that diagnosis with a 35-year-old unless she's very, very obese. I haven't seen her body habitus or any descriptions of that, but I'm assuming that is either not pertinent or it is something that might suspect some sort of underlying rheumatological disorder. Didn't sound like there were any rashes or anything like that. There were no other medical comorbidities that you would point you in an autoimmune or sort of autoinflammatory direction. The family history is also pretty nonspecific. Although I will say, for a grandmother to be diagnosed with heart failure and I believe you said in her age 59, is that correct, Sukriti? Yeah,
Yes,
so
that's
that's
correct.
still a little on the young side, definitely under age 50, of course. What I always ask my patients that I'm seeing is, did anyone die under the age of 50 under any circumstances whatsoever, even if it was just as long as it was unexpected? And sometimes you get a hit just on, say, a car accident and the person was driving, right? Because if they have a primary arrhythmic disorder, that itself could present as just a sudden cardiac death while driving into an accident or something like that. So, I try to keep it broad. I try not to focus so much on heart and just say, did anyone die suddenly? 59, again, is still above that threshold, but to hear that she did have heart failure makes some sort of familial presentation still a possibility, even though clearly her grandmother was a much older age than this patient is presenting. We've seen that many, many times that even in a very clear family with a genetic variant, with a genetic cardiomyopathy or arrhythmic disease, we can still see variable presentations because we don't understand everything about genetics. And there's probably a lot of background modifiers, exposures, etc., that then can modify how these people present over time. It is interesting that this woman had two children and had no major complications. So again, I don't know when the last child was born, but if it's been years since then, it does make me wonder whether this is probably more of an acute thing, because I always say, and I've seen it myself with my wife and our two children, pregnancy, in my opinion, is a heart failure state. So for her to have gone through through that sort of physiological condition without much problem, generally says to me that her heart, at least at that time, was probably much better than it is now. Especially if she didn't have any arrhythmias, given the fact that she has frank VT at this point. But yeah, I mean, other than that, unfortunately, does not really take anything out of the picture. The only other question I might have, again, just because this is what I do, I see a lot of sarcoid, is I always ask about whether people have any undiagnosed or diagnosed lung disease, like asthma, anything like that. Yeah, people can have asthma at age 35, but if I then follow up by saying, well, when were you diagnosed? Did you have it as a child? Because if someone was told they had asthma at age 30 and never had any symptoms when they were like age 16 to 22, just ballpark, that raises my sort of red flag alert that this may not just be your run-of-the-mill asthma, but something that developed over time. And then I start thinking about things like sarcoid, et cetera.
That was great. I have a quick question for you, Dr. Pan. And just piggybacking on what you said about like asking for the potential red flags that could indicate like sarcoid. What are other things that you like red flags that you ask for in history when like approaching an unknown infiltrative cardiomyopathy?
Yeah, so along the sort of sarcoid lines again, I go head to toe again because see so many patients with systemic conditions that can affect the heart. So I always say it to my trainees, we're all cardiologists, don't get me wrong. We spend our lives focusing on the heart, but remember that heart belongs in a body. And there's clues everywhere else too. So eyes are very important. I can't tell you how many times basically a patient has gone to me and the first sign that they had an inflammatory disorder was something going on in their eyes. I've had patients presenting with glaucoma or uveitis is the prototypical one. And the way I ask about that is, have you ever had pain in your eyes? I don't, say blurriness or things like that, because that can be a whole different things. But have you actually ever had pain in your eyes, one or the other? And specifically, did you ever, and most people have seen an eye doctor if that's the case. The other question is, did you ever had to get eye drops? And if you did get eye drops, what was it? Because if it was just, saline solution, maybe it's just conjunctivitis. But if they tell you, I got steroid eye drops, that's a real red flag, because people don't always remember what exactly the treatment is, but they remember someone telling them it was steroids, right? And that's an anti-inflammatory. So if there's an inflammatory condition in the eye, that makes them worry about inflammatory conditions elsewhere. I already talked about the lung stuff regarding sarcoid, and then just in general, if rashes anywhere, joint pains that would be unusual, things of that nature. Um, you know, I think it's unlikely at this age, but if you're also looking at other infiltrative disorders like amyloidosis, so say this person was like 60 or 70, I would be asking about things that you would already sort of refer to as carpal tunnel, neuropathy, the biceps tendon rupture, which when I first heard about that association with amyloidosis, I thought that must be so rare. But once I started asking, I saw it everywhere. So don't neglect to ask that question because people aren't going to think that that's related, and they won't tell you if you don't ask. That's for sure. The other thing I think that does come up that we oftentimes do not ask about is GI symptoms. And that is something that is associated with a lot of different infiltratory disorders because, again, if these are systemic conditions, whether it be inflammation or deposition of amyloid deposits, these things can affect the gut. And I've had quite a few patients actually referred to me from a gastroenterologist just because an incidental biopsy actually showed evidence of some deposition or some inflammatory disease like a granulomatous inflammation. So asking about those GI symptoms, that can be, any diarrhea or constipation, etc. And especially if they have had a history of bloody stool or been diagnosed with something like inflammatory bowel disease, that's very concerning. The other thing I would say about that is outside of the infiltrative sphere, just keep in mind that ulcerative colitis and Crohn's disease, both inflammatory bowel disorders, are also strangely associated with giant cell myocarditis, which is another condition that this could be. And if you always want to keep an eye out for that, because that has a terrible morbidity and mortality, and those patients need to head for transplant as soon as you make that diagnosis.
That's awesome. Thank you, Dr. Pan. Back to you, Sukriti.
Great. So to give you more history, the physical exam. So in the clinic, her heart rate we found was 80, blood pressure was 115 by 71. Her oxygen saturation was normal. She was well built and nourished, just going from head to toe. So her neck, there was no JVD, no carotid bruise that we could auscultate. Her lung sounds were clear. Bilaterally, there were no added sounds. Cardiovascular exam was normal too, regular rhythm. S1, S2 were heard. There were no murmurs. The abdomen was soft, symmetric, non-tender. No edema in her extremities, and essentially no neurological deficits. So it was all in all a very benign exam. And some of the things that Dr. Pan alluded to earlier, things like rashes or like joint swelling, none of those signs were present. So going on to the labs, so some basic labs. Her CBC was also unremarkable. Just for the audience, the hemoglobin was 12.8, platelet count was 340, WBC was 5.74. Similarly, the BMP was unremarkable. Creatinine was 0.5, sodium 140, potassium 4.1, and her bicarb was 22. Coming to some more cardio-specific labs. So her high sensitivity troponin, this was partly drawn in the hospital during her stay with the left heart during her workup, her ischemic workup. But her high sensitivity troponin was essentially normal. It was between 11 to 14. Her pro-BNP was 174. She also had a lipid panel done, which was also normal. Her LDL was 70, total cholesterol was 161, HDL was 73, and triglycerides were 94. Additionally, a TSH with reflex T4 was done, which was normal. She had a urine drug screen, which was also normal, and she did also have an angiotensin converting enzyme assay, which was within normal limits. Other than that, an ECG was done, which showed similar to her baseline sinus rhythm and that 2 mm ST segment elevation in V2. And chest X-ray showed that there was no active cardiopulmonary process and her cardiopulmonary silhouette was within normal limits. So just a whole lot of normal things. But I guess my question for Dr. Pan is that while approaching I know we talked about some of the signs, but while approaching the labs, what are some of the red flags that you look for?
Yeah, so as you sort of alluded, this is a pretty unhelpful lab panel. But I think the red flags, of course, if the troponin is positive, that of course is very, very concerning, right? Because then, troponin does not mean just ischemia. It is a marker of myocardial injury. Many of the myocarditis, and I just mentioned giant cell, for example, will have a positive troponin. And I think um, when you see a positive troponin in a case like this, that just tells you that you need to work this patient up quickly and assess them quickly because things can change on a dime. So it's sort of a marker of not just what this could be, but how fast something like this could progress if the troponin is positive. The NT-proBNP, of course, is always very helpful in terms of risk stratification. It's very low in this patient, so that's reassuring. But at the same time, things can change. Just remember, all these labs are, a single moment in time, and of course can change in a matter of hours to days. Other than that, in terms of it, so I will one thing I will say is that a normal ACE level rules out nothing. I can't even tell you. I've been meaning that I should actually just go and investigate this fully, but it is my observation that basically the majority of my patients with full-blown cardiac sarcoid have completely normal ACE levels. It doesn't keep me from checking it every single time I see them, just in case, because I'm frankly very concerned about the chance of recurrence in any patient with a history of cardiac sarcoidosis. But I would tell you that the majority of them don't have a positive ACE level. However, what I will say is if you do have a positive ACE level, then that patient deserves a full investigation and a full rule out of cardiac sarcoid because there isn't a whole lot of other things that can cause that to be elevated. And when I say elevated, it really just needs to be elevated a small amount. I believe, at least on our lab range, the normal is about less than like 75 or 80. And I've seen patients with an ACE level of like 85 who've turned out to have full blown, not just cardiac, but whole body sarcoid. So there's really not a whole lot of room for interpretation in that number. It's kind of, unfortunately, it's not as good of a lab as we would like. The other lab that I haven't heard about that I really would like to know about in this young woman would be assessments of inflammation. So CRP and ESR. I use a high sensitivity CRP just to get a little bit better detection of any underlying inflammation. And a lab that I've started to use that I know isn't commonly used and can be difficult to get is a soluble IL-2 receptor level. Not very often that any cardiologist would ever know what that is, but it has been associated with sarcoid disease activity. Unfortunately, just like the ESR and CRP, it is somewhat nonspecific. It is the sort of the same level that we often check with patients with HLH, hemophalangeal H. Okay, leukohistiocytosis. Anyway, it is a condition that is also very, very inflammatory. So it's not very terribly specific, but something that even if if the ESR and CRP are normal, sometimes the soluble IL-2 receptor level will be elevated. Um, Apart from that, there isn't a whole lot of other blood work I think that's going to be too particularly helpful. Just routine things that I would check in a young person presenting with a non-ischemic cardiomyopathy would be things like HIV, other viral, if there's any history of a URI, I might just send a viral swab just to make sure, although it doesn't sound like that's the case here. You might want to check hepatitis just in case, because some of those viral infections can have some cardiac issues. But again, in a case like this, that also seems extremely unlikely. So.
I had two questions for you, Dr. Ben. The first one is, do you track any of these labs? Say if you do make a diagnosis, or any of the do you use the troponin or pro-BNP? Is that something that you would order at subsequent clinic visits? And
Yeah.
then oh,
Okay.
sorry, yes.
Sorry, no, finish. That's your second question.
Oh, and then the second question was with the chest X-ray showing, essentially being normal, does that make you think that this is less likely to be sarcoid? Like just thinking about like lymphadenopathy, not seeing hilar lymphadenopathy on that chest X-ray, how good of a test do you think it is?
Yeah, so I'll start with the second question first. It means nothing. Chest X-rays, they're great, but they're not, there's a reason why we have CT scans, especially when you're talking about high lymphadenopathy. It has to be super bulky before you'll see it on a chest X-ray, and by that point, honestly, patients, usually the diagnosis is pretty clear at that point. There's so many other manifestations of sarcoid disease that it would really be apparent. So I think a normal, quote unquote, normal chest X-ray to me, especially in any young patient presenting with HFrEF and arrhythmias, really does not rule out sarcoid whatsoever. And I say at the very minimum, these patients need a CT scan of their chest to look for that lymphadenopathy, and that's at a minimum. In terms of uh, following blood tests, for infiltrative diseases, I do routinely check cardiac biomarkers. Again, the yield has been plus minus, and this has also been borne out in the literature. Even BNP there's a lot of controversy about how much utilization there really is in checking in BNP with every single clinic visit. But I still do it. I think it's easy enough as it is, and I think for certain disease conditions, especially things like cardiac amyloidosis, there is some growing data that can be very helpful in how to guide treatment. Like I said before, if someone's had a negative troponin before and all of a sudden now the troponin is positive, I think for me that's a real concern. That is, for example, if it's a chronic myocarditis, that something is flaring up again.
That was awesome. Okay, so this is something that I guess we're all as people in cardiology, we all love to get this information, and that's the results of the echo. So the echo essentially showed I feel like I'm contradicting myself, but I promise I do have more information. So the echo showed normal LV wall thickness and systolic function. EF was 60 to 65. There was reported a focal area of dyskinesis along the inferior interventricular septum, which was interpreted as possibly representing congenital abnormality with prior mid-muscular VSD. However, there was no evidence of shunt bicolor flow. Otherwise, RV systolic function was normal, and there was no significant valvular pathology. And then there was also a cardiac MRI done. This was done because the patient, although when the patient was shown to have a VT, they did get a cardiac MRI as part of the workup. And the cardiac MRI showed segmental akinesis with bulging and delayed enhancement, representing scar or infarct involving the anteroseptal mid-left ventricle. They also said there was LV systolic dysfunction with decreased ejection fraction, 40%, and right ventricular diastolic dysfunction with decreased stroke volume. I don't know if the scribe, I'm sorry, not sure who's scribing, but if you would like me to repeat anything, I can just put it in the chat as well.
And then on that MRI, can I just ask, did they do delayed gadolinium enhancement?
They did, Dr. Ben. They said 33%. That was 33. I'll just pull it up, but I think they called 33% delayed gadolinium enhancement involving the anteroseptal region of the left ventricle.
Use 33%? Really?
Yeah,
Of the
yeah.
segment or the whole heart?
Uh, Let me just confirm. I think it was a segment.
I hope it was a segment for this patient's prognosis. The reason I bring it up, as you may be
Yeah,
aware, there's quantification now of delayed enhancement, for example, in HCM, and
yeah.
growing body of evidence for that for, arrhythmic outcomes in DCM. And, usually when we're talking about that, we're talking about like 10 or 15%. So when you say 33%, to me, that's very scary, because that's a lot of scar if that's the case.
So I just pulled up the report. So let me just read it out to you. They said there was akinesis with focal bulging involving the anteroseptal mid-LV wall associated with near transmural decreased perfusion and delayed enhancement identified as 33%, so 21 grams.
Got it. Yeah. So that's a lot of scar. So especially when they use the words neurotransmural. And I will just put this out there. Anytime I see somebody who's got a clear case of a non-ischemic cardiomyopathy, when I say clear, meaning the cath is negative, there's no way that there was some embolic phenomenon, there's no history of hypercoag, that there's just no way this person ever had an MI. And you see something that's either transmural or near transmural on an MRI in terms of scar pattern, you really, really have to think of sarcoid because there's very few things that can mimic a segmental MI like that. It has to be something that's very inflammatory and yet very focal. And sarcoid is like number one, two, and three of those things. So when I see that in MRI, that's my next step is, okay, how am I going to diagnose this patient or rule this person out for sarcoid disease?
And then I guess the other question was, are there any other differentials that you would be keeping in mind?
Yeah, so again, sarcoid is, just to back up a bit, sarcoid is a myocarditis. So basically, you still have to worry about all the other myocarditis. So viral again, but again, given the fact that this doesn't seem like it's an acute case, that would make me wonder if it is, a viral myocarditis, then it would have been something that maybe occurred, years ago or months ago and has the viral infection has resolved, and now we're left with this scar. It's just that the amount of scar in this setting does make me concerned that that's not going to be likely, but still something on the differential. I mentioned giant cell, and of course, the reason why I mentioned giant cell is because you think of things that can kill somebody very quickly. Giant cell is one of those things when you talk about inflammatory heart disease. So we're always trying to rule out giant cell, and if you're going to biopsy someone, that's usually the reason to biopsy someone is to rule out giant cell. If it's on and in someone both with a cardiomyopathy, although I understand the EF is normal, but there's clearly still something going on based on the MRI. I would still call this a cardiomyopathy based on the MRI results alone, despite the preserved EF, plus the arrhythmias. Giant cell is still very much on the differential here.
And what would be your next step, Dr. Ben?
So I think a lot of it depends on the stability of the patient and the sort of time frame that you have to make a diagnosis here. I'm assuming at this point the patient is inpatient, so we can do the things that anything that we want to do. The area that was affected, if I remember correctly, was the anteroseptal area on the MRI. Is that correct? Um, so, there is a school of thought that you could go straight to biopsy. The reason why you may hear me not be so overly enthusiastic about that is, and this is where, a picture's worth 1,000 words. Reports are reports, but I myself, as a heart failure cardiologist, look at MRIs myself. Not that I ever disagree with our MRI readers, but for my purposes, it helps me understand just where the affected area is and how approachable that area is from a blind RV biopsy. As it's not technically blind, but at the end of the day, we're always tend to biopsy the same areas for both because that's the way the bioptome goes, and two, that's the area that's safe. We can't biopsy the free wall of the RV, and I personally never biopsy the LV, although I know there are a few centers that have tried to do that. So part of looking at the images is trying to figure out, is this an area that is approachable for a biopsy? Because to be honest, that is oftentimes the quickest way to get to a diagnosis in a case like this. But it is fraught with the possibility that you might get nothing, and then you're still back at square one, having done this invasive procedure. Another possibility here, depending on, again, the time frame and acuity of disease, is a cardiac PET scan. If you're concerned about an acute inflammatory issue, a PET scan can be very helpful. The issue is sometimes is oftentimes logistics. Depending on your hospital system, PET scans may not be available even as an inpatient. And especially if a patient is in any way unstable, getting a PET scan, which can take some time and may oftentimes be in a completely different building, like it is in our center, is not feasible. But those are the two options in a case like this. I would say if a patient's very, very sick, the biopsy is probably the way you have to go, because you can always take the patient to the cath lab even if you need mechanical support, and you don't need to worry about them being a scanner for like 20 or 30 minutes or in a different building. Whereas if the condition is a little bit more of a semi-stable, like on telemetry or even as an outpatient, PET scan is oftentimes my first choice. And the reason why is then the PET scan adds further information, not just what it could be, but also a target for eventual biopsy for diagnosis. So, for example, if the heart area is not approachable from an RV endocardial biopsy, maybe there's a lymph node that I didn't know about that I could approach. So either superficially or through endobronchial means, or maybe there's an abdominal lymph node that can be approached from a CT biopsy. So all sorts of other possibilities. So the PET scan isn't even just a diagnostic test, but also more of a planning test to let me know where we can get tissue.
And say we were in a resource limited setting, would empirical therapy with like steroids ever be an option, do you think?
I think in a setting where someone is very ill, steroids is never a bad choice. I think there's uh, the only downside would be if someone's possibly septic, and even in that scenario these days, there's more and more evidence now that actually steroids may be helpful in sepsis. So I think there's very little downside. I will say that I generally try to avoid giving steroids too early if a patient's not too ill, because the issue is that the crux of this is that you really need to get to a diagnosis to sort of guide long-term treatment. Because whatever this is, especially in a 35-year-old woman, this is going to be something that's probably going to need chronic therapy long-term. And if you never get to a good diagnosis, then you sort of don't know what to treat. And I think that incurs sometimes more danger later on. So we try to avoid empiric therapy unless it's absolutely necessary for the patient's safety.
You had the diagnosis from the start, but so this patient did undergo a PET scan, and we found that she had cardiac sarcoidosis. And in terms of her treatment, we started her on steroids. For the VT, she did undergo a VT ablation. But I wanted to get your thoughts on this. Was you talking to the electrophysiologist about this? Is this a patient that you would put an ICD in?
Absolutely. I think there's no doubt. If you look at, actually, I always joke about this with my EP colleagues. If you look at the heart rhythm sort of guidelines for patients with cardiac sarcoidosis, um, it's sort of, it goes by like, does the patient have VT? Well, then yes. And in this case, she had a history of VT, so you're already there. But even if you don't have a history of VT, and even if you have a normal EF, and even if, you don't have a ton of PVCs or anything like that, there is still like a lot of push, if you look at that flow chart, to try to get someone to an ICD, whether it's right or wrong. And I think the problem here is that there just aren't great randomized control trials. In fact, there's no randomized control trials, as far as I'm aware, maybe one in cardiac sarcoidosis. And that randomized control trial was methotrexate, and I think in a total N of about 20-25 patients, just so you know. So they're just not good data. And I think what I always tell my colleagues is what really makes me nervous about cardiac sarcoid patients is getting a call in the middle of the night that someone's died of VT, and I could have stopped that. So, I think if you look at other sort of similar disease procedures, we always started with giving ICDs to everybody and then sort of backing down, developing better risk stratification schema, et cetera, over time. And I hope one day that with cardiac sarcoid, we get to a point where that can be something that we can have some sort of risk stratification that's beyond just you have sarcoid, get an ICD. But I think at this point, there's very little ways to escape a diagnosis of cardiac sarcoid without some sort of rhythm monitoring device. One thing that I find particularly helpful is an EP study. If someone doesn't meet clear criteria for an ICD, but has a very clear-cut diagnosis of cardiac sarcoid, I think an EP study can be very useful to help risk stratify. There was a great study out of Mount Sinai where they looked at that, and basically patients who had a negative EP study had, I think, greater than 90% survival over the next few years, free of arrhythmic events. Note that that's not 100% though. And so that's still a little concerning. And I will say that in my patients who have a negative EP study, I still beg the EP to put an ILR in so we have good long-term rhythm monitoring. But if the EP study is clearly elicitable VT, you're done, ICD goes in, and we go from there. But also remember, and I'm sure I don't have to tell this audience, just because you have an ICD doesn't mean your VT is fixed. And so I absolutely agree that patients like with cardiac sarcoid, where the inflammation is treated and has resolved, VT ablation can still be a key need in the management of these patients. Of course, we know that antiarrhythmics, unfortunately, have more toxicity and actually lead to worse outcomes than undergoing a VT ablation or catheter-based ablation first strategy. I do think, though, that it is worth one try of getting the inflammation under control and then reassessing the VT sometimes. Although I will say it sometimes even goes the opposite way, where someone has had no VT initially, you treat, the inflammation goes away, and then they develop VT because the scar has now solidified, and you get reentrant circuits. So it kind of, I will say that the initial presentation of cardiac sarcoid does not always say that someone's going to be totally safe later on in terms of their arrhythmic risk.
That was a great breakdown. So in our case, before the diagnosis of sarcoidosis had been made, the patient underwent the VT ablation. But it was like good to learn from you that the VT ablation does not preclude putting in ICD. The substrate is still there.
Absolutely not. Especially in a case where you have inflammation that can either still be active or recur. I think unlike, for example, I mentioned Purkinje fiber VT, where we know there's a structural issue, you're able to ablate it. Again, not an EP, but this is what my EP people tell me. There's no ongoing process, and so you're fine. You've cured the VT. This is a very different scenario where basically you can ablate the area that is causing the VT now, but another spot of sarcoid can show up or get worse later and then cause more VT in another area, which is why really our approach to these patients who have significant arrhythmic burden is really to provide a level of protection.
Deborah, I think you had a question that you posted in the chat for Dr. Penn. Do you want to ask him?
Yeah, it was like before we got the PET-CT with confirming the diagnosis, like when you saw this MRI and you thought this was really suggesting for the cardiac sarcoidosis, if you would order the IL-2 receptor for this patient.
Yeah, I would have. The problem is, as you might guess, is that soluble IL-2 receptor takes about like a week to come back because it's always a send out. So I will be honest with you, it's not always a great diagnostic test, looking forward. But oftentimes it's the retrospective, like, oh yes, there it was. Yeah, it was positive then. So yeah, this all makes sense now. Or if there's a slower sort of presentation, then I can sort of go back and say, hey, that was positive. I need to look into this sarcoid possibility more. But yeah, I would order all those inflammatory blood tests up front in someone like this young woman with with signs of a cardiomyopathy and arrhythmias. I think I order these in sort of inflammatory labs in all these patients just to get a better assessment of what the inflammatory milieu is.
That's awesome. Thank you so much, Dr. Pan. I have one question here. Once you have an established diagnosis of cardiac sarcoidosis and you start empirical management steroids, do you have any protocol to have any surveillance for the imaging and how often and how do you monitor for the therapy?
Yeah. So I give full credit to Ron Ratellis at Stanford, who I trained with. He has published, him and his colleagues have published several papers on this, and I think it's been something that's more widely adopted now, is that generally, especially we use PET scans predominantly to monitor response. Of course, you have everything else, the rhythmic burden, the echo, the ejection fraction on echo, and other assessments, of course, of the patients. But at the end of the day, we generally use to sort of titrate our immunomodulatory therapy is imaging. It's something that I don't love because imaging is not perfect in any way, especially cardiac PET scans are not perfect. And I can go, if somebody really wants to know, I can talk for some time about that. But in general, we usually use about 3-month intervals. And I think honestly, that's just sort of adapted from echo guidance, right? We get repeat echoes in 3 months after GDMT. Sort of the same thing here. I will say that observationally, anytime I've tried to get the PET scan a little earlier, it's burned me because then I really don't know if things are really worse or if it's just because I did it too early. And so I do try to end up waiting a full 3 months, if not more. Again, sort of like, echo and GDMT, doing it too early can oftentimes be a frustrating experience. So I really try to keep these patients on treatment for a full 3 months. That can be very frustrating for patients because, as you guys know, the primary therapy often is steroids and quite high dose steroids. I generally use at least 40 milligrams PO of prednisone daily, and a lot of centers you will use 1 mg per kg. So the dose can be even higher to up to 70 or 80 milligrams. And so keeping them at a level of that amount for 3 months can lead to a lot of other issues in terms of hypertension, bone density, etc. It's diabetes. So it's something that I don't love. It's like taking a hammer to a gigantic sledgehammer to a nail, but it is what we have. And so
Thank you so much, Dr. Pan. And as I mentioned, we are so lucky to have you today, and we learned so much about the nuances of cardiac sarcoidosis. For the all young learners and listeners, if you wanna give three clinical pearls to take away from this lecture, so what do you have?
So what I would say is, always beware of the young patient presenting with heart failure. And especially if there's an arrhythmic component, then you really have to worry about inflammatory heart disease. I think that's the, 1, 2, and 3 need to rule out giant cell sarcoid and then myocarditis. Those three things have to be ruled out immediately because, again, those are things that can really rapidly progress and kill people. Um, I would say that, just as Sukriti sort of referred to, the findings, especially the cardiac imaging findings of sarcoidosis, can be quite subtle. If you just looked at the echo in this patient in her initial presentation, this focal area of dyskinesis around the IB septum, I don't think any of us on a report would have jumped at that really and said, that's it, So just be aware, a normal echo unfortunately does not rule out cardiac sarcoid, especially in a patient who's had VT. And I think at the end of the day, what really makes diagnoses in cases like this is an MRI. And I think, from my perspective, and I think it's a growing perspective, is that MRI can be very, very helpful in the diagnosis of non-ischemic cardiomyopathy, especially in young people.
That's wonderful. Thank you so much. So, Sukriti, do you have any final reflections from this case? By the way, thank you so much for putting this case together. And I really learned a lot. I'm gonna rewatch this video multiple times.
No, I think I just want to thank Dr. Pan today for making time to teach us all. And I think I'm gonna watch this too, Rahul. And I loved some of the pearls he gave. Even on how to ask for uveitis. I think I'm going to use that in my clinical practice, thinking about like eye pain and steroid drops. So thank you so much again, Dr. Pan.
No, it's my pleasure. As you can tell, I love talking about sarcoid. I don't love treating it, both for my sake and the patient's sake, but I do love talking about it. So.
That's wonderful. And thank you so much, everyone, for joining. And thank you so much, Deborah and Lyra and Vale for doing the scribing. And thanks, Shreya, for keeping up with the teaching point for the first time. And I hope you have a great rest of the day. Thank you so much. Bye bye.